My name is Prabhleel Chahal. I'm an advanced endoscopist at Cleveland Clinic. I'm also director of advanced endoscopy training at my program. I would like to thank the organizers for giving me an opportunity. And today we're going to talk about endoscopic ultrasound evaluation of liver and liver biopsy. I'll start this presentation with anatomy of liver. As the field of endohepatology expands, it becomes imperative for us to understand the anatomy of the liver in a little bit more depth. This picture shows Quinault classification. According to Quinault classification, the liver is divided into 8 functionally independent segments. Each segment has its own vascular inflow, outflow, and biliary drainage. In the center of each segment, there is a branch of the portal vein, hepatic artery, and bile duct. And the periphery of each segment has a vascular outflow via hepatic vein, which drain into the IVC. The right hepatic vein, it divides the right lobe into anterior and posterior segments. The middle hepatic vein divides the liver into right and left hepatic lobes. And the falciform ligament, which is not visible in this image, it divides the left hepatic lobe into medial segment 4 and lateral segment 2 and 3. The portal vein divides the liver into upper and lower segments. As we embark on performing endoscopic ultrasound evaluation of liver or liver biopsy, there are 3 main stations that we encounter: closer to the HEE junction along the lesser curvature, followed by antrum, and finally the duodenal stations. As we enter the stomach, segment 2 and 3 are readily seen, and as we further move down into the antrum, we can see segment 4, and into the duodenum, we can see segment 4 more clearly, and then part of the right lobe liver like segment 8, etc. So I borrowed these images from Ken Chang's paper published in Endoscopic Ultrasound from 2018, where he very eloquently described EUS anatomy of the liver. Similarly, Dr. Vikram Padia had described this anatomy again beautifully in his paper published in Digestive Endoscopy in 2013, and I don't think I could have done a better job than these two guys. So first of all, in this image, this is the image that is obtained when the probe enters across the GE junction. You turn counterclockwise, and as you look upward, you see the liver, and segment 2 is closer to the probe and segment 3 is away from the probe. And the dividing these two segments is the left hepatic vein. Some important things to keep in mind is the portal vein and the branches of the portal vein, like this marked here, they have a thick hyperechoic walls, whereas bile duct is anechoic without any echogenic wall. Hepatic vein also, they don't have significantly thick or echogenic walls. So you see this beautiful longitudinal left hepatic vein. Now, as you push the endoscope in a little bit more and turn clockwise, you see a thick echogenic band, that's the ligament teres, originating from the umbilical portion of the portal vein. And as we continue to turn clockward, you see the ligament venosum. And as you pull the endoscope back out a little bit and turn more clockwise, you can see the middle hepatic vein draining into the inferior vena cava. And then segment 1, the caudate lobe, and segment 8 is also visible, with ligament venosum dividing the segment 1 and 4. Now this is the view that is obtained after you have identified the ligament venosum. And then as you push the endoscope a little bit, you can see the hepatic hilum, where the triad is seen. Closer to the probe, while you're in the stomach, is the portal vein, followed by hepatic artery in the middle, and the bile duct is the farthest from the probe. Whereas as you move down into the duodenum, this is reversed, where the bile duct is closest to the probe, followed by hepatic artery, and the portal vein is the farthest. From the bulb, you can also see the branching of the portal vein, with the left portal vein going away from you and the right portal vein towards the transducer. And similarly, segment 4, caudate lobe, can easily be seen from the duodenum. So if there's a mass located in the segment 4, either from the antrum or from the bulb, it can be accessed. So as I mentioned, there is an emerging role of endohepatology, and we use endoscopic ultrasound at our institution and across the world where the expertise is available routinely for detection of and diagnosis of occult liver metastases. Again, significant amount of data shows endoscopic ultrasound is superior than CT scan in detecting metastases smaller in size, example 5 millimeter or small. We use this routinely for diagnosing and staging the liver tumor. Our center performed liver transplants for cholangiocarcinoma, and then endoscopic ultrasound is used for nodal staging with the data supporting its utility for this particular indication. Again, we have an emerging role for portal pressure measurement. There are data on portal thrombus or tumor thrombus by needle aspiration, use of portovenous circulating tumor cell evaluation for staging of the tumor and for prognostication. We use fiducial placement in the liver for adequate treatment of the liver tumors. And of course, as everybody knows, endoscopic ultrasound is also routinely used for biliary interventions for drainage procedures, abscess, or for palliation of jaundice. Last but not the least, there is again emerging data on the role and use of radiofrequency ablation via endoscopic ultrasound for liver tumors. Moving on to liver biopsy. The first liver biopsy was performed in Germany in 1923 percutaneously, and almost 40 years later, first transjugular liver biopsy was performed by interventional radiologist Charles Daughter. It took another 40 years before first endoscopic ultrasound-guided porcine liver biopsy was performed in 2002, and the first report of EUS-guided liver biopsy in humans was reported in 2005 in 2 patients. So we've come a long way. What are the indications for liver biopsy? I think the most common indication is the metastases. You are staging the pancreatic cancer patient, and you always look for liver metastases for staging of the tumor for biopsy. Another common indication is abnormal liver test. Patients without any other explanation, they are coming in for endoscopy. We perform endoscopic ultrasound-guided liver biopsy for diagnosis. It is also used for diagnosis and stratification of overlap liver diseases, like drug-induced liver disease or autoimmune hepatitis, for diagnosis and staging of non-alcoholic steatohepatitis, in the management of chronic viral liver disease, autoimmune hepatitis, and for systemic diseases like amyloidosis or sarcoidosis. The advantages of liver biopsy include being able to access both lobes of the liver. That being said, the left hepatic lobe is much easier as far as the access goes. Right, majority of the times is easy, but sometimes it could be difficult, especially if you're trying to use a 19 gauge needle. Being able to look at intervening vessels via Doppler help us minimize the risk of bleeding. The procedure obviously is better tolerated as patients are under sedation. Endoscopic ultrasound also allows us to precisely localize the lesion and characterize them. And we can also perform endoscopic ultrasound-guided liver biopsy in patients who may have had contraindication for percutaneous liver biopsy, like ascites. It also allows for quick recovery, in contrast to percutaneous biopsy, where the recovery period often is 4 hours long. And I would dare to say that this is safer than percutaneous liver biopsy. There are some disadvantages, and I would like to start with the top of the list as lack of standardized technique, as we'll talk about this a little bit later. Endoscopic ultrasound is an expensive test, and if this is conducted solely for liver biopsy, I'm not sure if the expense can be justified at this point. There are also some concern about the size of the core that can be obtained via EUS guided biopsy with the needles that are available, including 19 gauge and 22 gauge. And then the concerns and forever challenges that we encounter with the tissue fragmentation despite due diligence that is taken at the time of tissue extraction from the needle. There are some adverse events, but all the reports so far suggest the adverse events, they range anywhere from 0 to up to 2.3%, majority being abdominal pain post-procedure. There are some reports of mild bleeding, self-limiting, that can happen in up to 1 to 2% of the patient, followed by risks including infection or bile leak, which are extremely rare. I don't know if you guys paid attention to the video. Here you could see branches of the portal vein with echogenic wall, and then this was the left hepatic vein coursing longitudinally, dividing the segment 2 and segment 3. So what constitutes adequate liver biopsy? If we look at the society guidelines, AASLD recommends that the core length should be at least 2 to 3 centimeter long or 20 to 30 millimeter long, and the core should have at least 11 complete portal tracts. They recommend a 16 gauge needle as an ideal needle size. EASL recommends core length to be minimum 15 millimeter. There is no definition on the number of complete portal tracts required, although more than 6 is something that is usually suggested. And again, the EASL also recommends 16 gauge needle as a preferred gauge. Asia Pacific also core length 15 millimeter, and they recommend getting at least 10 complete portal tracts, and again, a preferred needle size being 16 gauge. Now with this background information about the society guidelines, let's talk about the conundrums that all of us face while performing liver biopsy. Should we do FNA or FNB, which translate into using an FNA type of a needle or an FNB type of a needle? Is 22 gauge enough, or should we have to go 19 gauge? And again, FNA versus FNB. If we are using FNB, should we go fork tip, should we go Francine, or reverse bevel, which translate into shark core or acquire or Procore? Should we be using suction? If so, how much? 10 cc, 20 cc's, no suction? Should we do slow stylet pull? Should we use the heparin technique, where the needle is flushed with heparin and then 2 cc of saline is aspirated into the suction needle, and while the suction is pulled back? This is the technique reported by the Geisinger group, David Deal. Or the wet suction, where either you can use heparin or you can use normal saline and flush the needle channel with it and then perform the biopsy. How many passes should we make? 1, 2, or 3? How should we extract the specimen from the needle? Should we be fanning? So all these conundrums, they exist, and I don't think we have robust data to answer each and every one of these conundrums. This is the most recent systematic review meta-analysis published in September 2020 in Surgical Endoscopy, whereby they included 23 studies. They had 1,326 patients. So 23 studies, 1,326 patients. And apologize for the small print, but as you see, the difference in terms of approach. Majority of them, they went for left lobe only. Some papers, they went for both right and left. The type of the needle was also quite variable, FNA versus FNB. Different needles used. The technique was also quite different, slow pull versus suction, varying degree of suction, 10 ml, 20 ml, wet suction, heparin. Number of passes ranged from 1 to 4. However, regardless of the technique, the needle type, FNA versus FNB, look at the diagnostic yield. The numbers are in high 90s. In this 23 study meta-analysis, they had 3 randomized controlled trials. So this was one of the drawbacks of the systematic review. Now, just going further down the list of the studies, including some of them published in 2020, using the expect sharp core needle, again, different techniques in terms of wet suction, slow stylet pull, but the diagnostic yield remains significantly high. So overall, the pooled mean total specimen length and complete portal tracts from the systematic review meta-analysis were quite impressive. 45 millimeter length of the core and a mean of 15 portal tracts. However, for the biopsy, complete portal tracts were a little bit higher compared to the fine needle aspirations. With biopsy, they were able to achieve 18 complete portal tracts versus 10 with FNA. And in terms of the technique, the FNB with slow pull or suction technique, they yielded similar total specimen length of 44 millimeter versus 53.9 millimeter. However, the slow pull technique performed better in terms of getting a complete portal tract, 30 versus 14.6 with other suction techniques, and the difference was significant. As I mentioned, there were only 3 RCT in the systematic review, and there was moderate heterogeneity in the systematic review meta-analysis. So the conclusion from this, FNB is better, slow stylet pull probably better in terms of getting more CPT. They did not find any significant difference between 19 gauge and 22 gauge. And for those of you who are asking the question whether we should go 19 or 22, again, the majority of the studies they use 19 gauge, as you see in the systematic review meta-analysis. However, there were some which used 22 gauge, published by Bazobachi from Mass General, again, 100% diagnostic yield, and another study using 22 gauge sharp core, which showed highly impressive results were by the Orlando group Hassan, where they used 22 gauge FNB. They biopsied both lobe except for 2 patients. They used no suction technique, made 3 passes with a wet suction, and the diagnostic yield for them was 100%. My personal preference, I toggle between 19 gauge and 22 gauge. I go slow stylet pull. I do fanning. I make about 1 to 2 actuations. I actually pull the stylet back about 3 to 4 centimeter before I thrust the needle into the liver, and then I ask my attendant to pull the stylet slowly while I make 1 to 2 actuations. I extract the specimen using the stylet back in. Rarely I've used, if I've used a wet suction, I would use a saline to expel the specimen out. I don't use heparin. I try to prevent the fragmentation. We don't shake the jar, and we basically label it as handle with care to prevent fragmentation. So what about liver biopsy in special scenarios like altered anatomy or post-transplant population or pediatric? Again, the data are very limited, basically limited to some case series or case reports. In the series published by Deal and by Hassan from Orlando group, they had about 2 patients each out of their entire cohort of 110 patients and 40 patients respectively who had altered anatomy, and they targeted left lobe. So obviously it's doable because regardless patient have Roux-en-Y gastric bypass or Whipple, we can always see the left lobe of the liver. Post-liver transplant is a little bit of a tricky population. At our institution, still the standard of care for post-transplant evaluation for abnormal LFT to rule out rejection is percutaneous biopsy. We are trying to persuade our liver surgeons, but there are just a couple small series that showed safety and efficacy. Similarly, there are a few case reports showing safety and efficacy of EUS guided liver biopsy using 19 gauge needle in pediatric population. So in conclusion, ladies and gentlemen, we are in an era of emerging field of endohepatology. It's imperative that we recognize, understand the anatomy of the liver in detail to maximize our chances of performing these procedures safely and effectively. There is lack of consensus on technique and technology for adequate liver biopsy. However, the existing evidence shows, regardless of the technique and technology, EUS guided liver biopsy is safe and effective. The cost and the expertise availability are limiting factors. However, I think a lot more people are gaining expertise in this procedure, and I'm sure that soon should be addressed in near future. And with that, I would like to conclude. And again, thank you again for giving me opportunity.
Hello, everybody. My name is Harshit Khara. I'm one of the interventional endoscopy physicians at Geisinger Medical Center from Pennsylvania, USA. And I would like to thank the organizers for giving me this opportunity and to join you on this virtual platform to share my experiences on transpapillary and transmural drainage of the gallbladder. As per the Tokyo 2018 consensus guidelines, patients with grade 1 or mild cholecystitis usually end up with supportive care and an early cholecystectomy. However, patients with grade 2 or moderate cholecystitis may not be immediate surgical candidates, and they initially require medical management with antibiotics and supportive care, and may require an urgent or early gallbladder drainage as a bridge to their surgical intervention eventually. The most interesting are the severe cholecystitis or the grade 3 patients who are not surgical candidates and may require medical management and may have other multi-organ issues with negative predictors for which they may not be immediate surgical candidates. Again, these patients require urgent or early gallbladder drainage. And in patients who have poor performance status and other medical comorbidities, they may not be a surgical candidate in the future at all, in which case the gallbladder drainage becomes their primary procedure. So these are the patients that we're going to focus on today and go over the modalities of their treatment. The first part would be a transpapillary gallbladder drainage. Now, this could be done in 2 ways, either as a nasocystic drain, endoscopically placed, or a transpapillary transcystic gallbladder drain or stent. So as per the Tokyo consensus guidelines for the management strategies for gallbladder drainage in patients with acute cholecystitis, a percutaneous transhepatic gallbladder drainage should be considered first as an alternative to surgical intervention in these high-risk surgical patients. However, they do include an endoscopic transpapillary gallbladder drainage as an alternative to PTGBD. Now, the endoscopic transpapillary gallbladder drainage would include a nasogallbladder drainage or a endoscopic gallbladder stenting. And another alternative, which is now included in the Tokyo 18 guidelines, which is not part of the Tokyo 13 guidelines, is the endoscopic ultrasound guided gallbladder drainage as an alternative modality of gallbladder. Now, these should be considered in high volume centers performed by skilled endoscopists requiring specialized techniques as well as specialized equipment. The clinical success rates of endoscopic gallbladder drainage is as high as 87%, with a low complication rate of 8%, which primarily includes stent migration, bleeding, cystic duct perforation, and biliary leak. The clinical success rates and the complication rates are similar between percutaneous and transpapillary drainages. There was no statistically significant difference in the technical or clinical success rates or the adverse event rate between the endoscopic nasogallbladder drainage or gallbladder stenting. The limitation with this technique obviously is that stent placement is not always successful. And this could be because of non-visualization of the cystic duct on cholangiography. There could be severe cystic duct stenosis with impacted stones at the neck of the gallbladder, which may impede the placement of a guide wire or an endoscopic stent. Another issue is the risk of serious complications, which usually arises from prolonged or unsuccessful procedures. And this risk would include post-ERCP pancreatitis or the perforation of a cystic duct or gallbladder. In regards to endoscopic transpapillary drainage, this is done under endoscopic and fluoroscopic guidance. Initially, transpapillary access is obtained to the biliary tree. And from the bile duct, the opening of the cystic duct is pursued under fluoroscopic guidance and maneuvering of an angled guide wire. My preferred wire of choice is an 0.025 angled guide wire that I'm able to maneuver across the cystic duct through the various twists and turns to be able to get access into the gallbladder lumen itself. I then follow this with a balloon catheter and then placement of a 5 French or 6 French double pigtailed plastic stent. This achieves internal drainage and also reduces patient discomfort of a transnasal drain. The alternative to endoscopic drainage would be an endoscopic ultrasound guide drainage of the gallbladder, which is a relatively new technology, and I'll share some of my personal experiences as well as scientific data around this procedure. So endoscopic ultrasound guided gallbladder drainage is performed either with a transgastric or transduodenal visualization of the gallbladder. Using a therapeutic echoendoscope, under endoscopic ultrasound vision as well as fluoroscopic vision, the gallbladder lumen is punctured, preferably with a 19 gauge or a 22 gauge needle. Contrast is injected through the needle to get a cholecystogram, and then a guide wire is placed to get access to the needle. Over this guide wire, a lumen opposing self-expanding fully covered metal stent can be placed for endoscopic decompression of the gallbladder, as seen here in this patient video. In my personal experience, I usually end up dilating the tract of the gallbladder in the same session to provide significant decompression of the gallbladder immediately. And as you can see, the reward is very satisfying with drainage of purulent material, and gallstones can be lavaged out, thus decompressing the patient's cholecystitis. EOS-guided gallbladder drainage has been extensively studied now over the past decade. an RCT of 80 patients in which patients were randomized to endoscopic ultrasound-guided gallbladder drainage versus percutaneous cholecystostomy. The technical success rate, which was upwards of 97%, and the clinical success rates were similar between the two modalities. However, with the EUS-guided gallbladder drainage, there were better 30-day adverse events rates. Reintervention rate was much lower at 2% as compared to 30%. The one-year adverse event rate was significantly lower at 25.6%. Unplanned readmissions of 15%, the risk of recurrent cholecystitis of only 2%, and post-procedural pain scores were all significantly lower as compared to percutaneous drainage. So when we compare EUS-guided gallbladder drainage to other endoscopic modalities of drainage, such as endoscopic transpapillary cholecystostomy, data has shown that there is greater technical success in the EUS-guided gallbladder drainage, as we saw in the earlier RCT, in upwards of 97 to 100%. ETC was associated with higher risk of adverse events, which is the transpapillary drainage. Recurrent cholecystitis and cholangitis were observed significantly lower in the EUS-guided gallbladder drainage group. These findings were also confirmed by a recent meta-analysis which compared EUS-guided gallbladder drainage to transpapillary drainage. EUS-GB had greater technical and clinical success rate without any difference in the overall adverse event rate. The most important part was the less risk of recurrent cholecystitis associated with the EUS-guided gallbladder drainage group. When we compare EUS-guided gallbladder drainage to percutaneous drainage, EUS-GB was associated with lower post-procedural adverse event rate, fewer rate of reinterventions, and significantly decreased length of stay with fewer readmissions. In network meta-analysis comparing all the three modalities, so comparing EUS-guided gallbladder drainage, endoscopic transpapillary drainage, as well as the percutaneous drainage, which had 10 studies comprising of 1,267 patients. EUS gallbladder drainage and percutaneous drainage had significantly higher technical and clinical success rates, but EUS-guided gallbladder drainage had the lowest risk of recurrent cholecystitis as compared to the other two modalities. The percutaneous gallbladder drainage had the highest risk of reintervention when compared to the other two modalities. So this is my own data at Geisinger Medical Center. We compared all the three groups with the EUS-guided gallbladder drainage, the percutaneous drainage, and then the transcystic drainage. This data was presented last year at DDW. And we found that there was significantly lower fluoroscopy time, post-procedure pain, opioid pain medication need, reintervention rate, risk of recurrent cholecystitis, as well as adverse event rate and hospital length of stay were significantly lower in the EUS-guided gallbladder drainage group. And the clinical success rate were similar. So what are some of the pitfalls of EUS-guided gallbladder drainage? Well, the adverse events, as we saw, one of them could be stent migration. So this patient had a successful EUS-guided gallbladder drainage, and on repeat intervention, the gallbladder could not be seen in the lumen. However, we found a fistula through which we were able to reestablish the connection between the gallbladder and the stomach, which was dilated, and we found the axios buried just under the gastric lumen, and the patency was reestablished by placement of a double pigtail plastic stent. So stent migration can occur. Now, I've seen this significantly in the transgastric drainage group, which could be attributed to the peristalsis and the food ingestion. Preferably, I try to do a transduodenal access to the gallbladder, but sometimes we go with wherever the feasible part is. Another issue could be stent occlusion. Now, this could happen even with a transduodenal access as seen in this patient. After EUS-guided gallbladder drainage, the patient presented with recurrent symptoms of cholecystitis and was found to have stent occlusion. This was endoscopically decompressed, and 2 double pigtail plastic stents were placed to establish repatency. Hence, in patients where I do endoscopic ultrasound-guided gallbladder drainage, I usually prefer to leave double pigtail plastic stents for two reasons. One, it reduces the stent slippage or tissue overgrowth and reduces the risk of stent occlusion. US-guided gallbladder drainage is also compared to laparoscopic cholecystectomy for acute cholecystitis. This study was done comparing these two modalities to see that not as an alternative, but what if this was a definitive therapy? Although this was a retrospective study over a 6-year period, comparing US-guided gallbladder drainage to lap cholecystectomy in propensity-matched patients. As you can see on this table, the technical success rate and the clinical success rate were similar. The length of stay, 30-day adverse event rate, 30-day mortality, risk of recurrent cholecystitis, recurrent biliary interventions, and reinterventions was not different between the two groups. The authors did post-USGB care where they performed per oral cholecystoscopy, 1 month post-procedure to clear any remaining stone, which has also been my practice. And if all the stones are cleared, the lamps can be removed and replaced with a 7 French double pigtail plastic stent. So these results suggested that the role of EUS-guided gallbladder drainage could be an alternative to laparoscopic cholecystectomy in patients who may or may not be surgically fit to undergo definitive cholecystectomy. Another important benefit is the clearance of the gallstones. So after performing an EUS-guided gallbladder drainage, we can actually enter in the same session through the lumen-opposing metal stent and perform definitive therapy to the stones in the gallbladder. This obviously is not feasible or possible with a percutaneous drainage or through a transpapillary nasocystic or transpapillary gallbladder stent. So in this patient, we found to have a large gallstone. We were able to successfully perform EUS-guided gallbladder drainage, dilate the lumen of the stent, and perform electrohydraulic lithotripsy in the same session, completely fragmenting the large stone and achieving stone clearance in the same setting. The large chunks of stone pieces were removed from the gallbladder using a snare, and then a double pigtail plastic stent was placed to prevent the risk of migration or stent occlusion. Another modality, as mentioned in the recent study, was that in patients where this is performed as a definitive therapy who may not be surgical candidates in the future, the lumen-opposing metal stent could be replaced to a double pigtail plastic stent, which could be then left indefinitely and thereby avoiding the need for a cholecystectomy in the future. So this patient had an EUS-guided gallbladder stent in a transduodenal modality who presented subsequently for removal of both the double pigtail plastic and the metal stent, and then through the existing cholecystoduodenal fistula, a 10 French by 5 centimeter double pigtail plastic stent was left as a permanent drainage option, and patient continues to do well without any recurrent symptoms or need for subsequent surgical intervention. Thus, in summary, gallbladder drainage is frequently chosen as an alternative to laparoscopic cholecystectomy in high-risk surgical patients. The short-term outcomes of EUS-guided gallbladder drainage are comparable to percutaneous transhepatic gallbladder drainage, but giving the added benefit that patients do not have a drain sticking out of their nose, and thus avoiding discomfort associated with either a nasocystic drain or an external percutaneous drain. EUSGB has a high technical success rate and clinical success rate with an acceptable adverse event rate similar to other modalities of gallbladder drainage. The preliminary data on long-term outcomes of EUS-guided gallbladder drainage with lumen-opposing metal stent appear promising compared to percutaneous as well as transpapillary, transnasal, and transcystic stenting. Thank you for this opportunity again to discuss this exciting topic close to my heart. And again, I thank the organizers for giving me the opportunity to share the podium on this amazing modality. Thank you.
Thank you, Dr. Harshit, for that very nice and lucid talk about US-guided gallbladder drainage versus transpapillary gallbladder drainage. So we have some time, 15 minutes for discussion. The first talk was a recorded one, so we can't have any questions for that talk. But this talk, we have Dr. Harshit live with us. So I invite my co-moderators and panelists to come forward with their questions. To start with, Dr. Harshit, I have one question regarding this gallbladder. So you said in one or two cases that you showed that the stent has migrated. Was that lumen opposing the axial stent which had migrated, or it was that normal metal stent which we put without the self opposing property? Which one?
It was the lumen opposing axial stent, and it had slipped into the lining of the stomach. So the stent had not fallen off. It was still just below the mucosa of the stomach.
Okay. So next, so what about the long-term patency? Suppose the stent even comes out, is the fistula maintained, or you have to always keep on exchanging the stents?
So the fistula is usually maintained, this just like any other fistula, especially transgastric or transduodenal, the fistula stays long term. Now we don't know again the long-term implications of this. Does it stay for 5 years, 10 years? And hence in these cases, I exchange it to a double pigtail plastic stent, which then can be left indefinitely. Or if the patient shows signs of recurrent symptoms, it could be from stent occlusion, and then we can go and do an as-needed exchange.
Yeah. So one more concern, one which I consider is a definite advantage of the US guided procedure is if we do a percutaneous gallbladder drainage, that the patient has to go for surgery later, because otherwise if you take out that drain, the patient is going to have bile leak. So that is a definite advantage if the patient is surgically not fit. So I think this has got definite advantage about the when comparing with the percutaneous procedure.
I definitely agree with you. In fact, we have had patients who got a percutaneous drainage at another hospital thinking they will get surgery in the future, but even for the future, they did not become a surgical candidate. So we actually use the percutaneous drain to inflate the gallbladder and then perform an EOS gallbladder drainage and remove the percutaneous drain in the same setting.
So one more, the technical point which I always fear is, like, in your experience, when you do this US guided procedure, how often do you find a contracted GB? Like, do you always find a distended GB when the procedure becomes relatively easy? But if you find a contracted GB, what do you do?
So as you said, usually if they have an obstructed gallbladder, usually it's nice and distended. So you just treat it like a pseudocyst and drain it. In a contracted gallbladder, then I use the needle puncture to inflate the gallbladder with contrast and sterile saline. The other place where the contracted gallbladder is if they've already had a percutaneous drain that has decompressed the gallbladder, and then I just use the drain to re-insufflate it. If the gallbladder is not fibrotic, usually that ends up distending very well.
Okay, thanks, Dr. Harshit. I would like to invite questions from other panelists and the co-moderators.
Dr. Sandeep. Dr. Sandeep, this is PP Bose. I just wanted congratulations to Dr. Harshit for his very nice talk and his innovative work on this. I just wanted to ask a few questions, like what are the reactions of the surgeon after the initial thing has tided over while doing a cholecystectomy, if it has to be done in these patients who were previously bad surgical risk, and after the initial improvement by the gallbladder drainage, the surgery could be done. And are there any special problems faced by the surgeon as far as the adhesion to the duodenum is formed to close the loop, and like this, vice versa? That's one question. The other question would be that do they routinely do a stone removal after the initial pus drainage of the USBD has been done? USGB drainage has been done on a second sitting. What's his take on this?
Thank you, Dr. Bose, for those great questions. So to answer the first question, in fact, in starting the program is always harder, because if the surgeons have confidence in you, then that's fine. But if these are not surgical cases, and if we end up creating a problem, if there is a stent migration or a perforation, now we're forcing the surgeons to go and operate in a patient that was not a high risk, very high risk surgical candidate to begin with. But once they have confidence in our technical skills and the data that we're able to show, now we get majority of our referrals from our surgical colleagues because they feel that putting a patient, it's the right thing to do for the patient. Putting them through a high-risk surgery when we can very easily decompress the patients and even as a definitive therapy. So majority of our surgical colleagues are the ones who actually call us for a consult for EOS guided gallbladder drainage. In patients as a bridge to surgery, they have not had problems with the laparoscopic work that they do. Like I said, there is usually a very nice matured fistula, and the surgeons are able to do a laparoscopic closure. In some cases, I was able to offer them endoscopic closure at the same time by placing a over-the-scope clip internally, and then they're able to dissect on the outside. And there was not a problem at all for the surgeons to remove it. In regards to the second question that you asked, these patients are high risk to begin with, but I usually do the same session stone removal if there is a large stone. If there is microcalculi, usually it's for pus drainage and decompression of the cholecystitis. I preferably use the 15 millimeter lamps, although 10 millimeter lamps can also be used. But usually with the 15 millimeter lamps, majority of the stones just decompress on their own. The one case that I shared, if there's a large calculi, I don't want that stone to cause an infection of the stent, in which case I do preemptively go and do an EHL and a stone clearance. And with other data, it has been shown it reduces the risk of recurrent symptoms in the future.
Thank you for your wonderful answers.
Can you
Dr.
hear?
Harshit, a small question on this in this regard. I would just, ask you that would you consider, say, since stent migration is one of the very important complications of this procedure, that since there will be a natural, well-defined fistula formation after a few, maybe 4 weeks or something, so can it be routinely? If the stent is in place, would you consider routinely removing the stent, say after 4 weeks or 6 weeks, so that in those patients who are not fit for surgery, they will have this permanent cholecystoduodenal fistula or cholecystogastric fistula. Once the fistula has been formed and you have the problems removed of stent migration and all that. Would this be a more physiological approach?
Absolutely, Dr. Bose. So that's what I preferentially do. It depends on the patient. It's almost a case-to-case thing. So I don't have a one-size-fits-all. If this is a palliative purpose for somebody who's elderly, 92-year-old patient, or somebody who has end-stage cirrhosis or something like that, then I do leave it in place because, in my opinion or in my experience, usually these stents don't have a problem up to a year, especially when you put a double pigtail stent. It actually holds the lambs in place. It prevents the migration. However, if there are younger patients who have a longer life expectancy, I do routinely go in and I do exchange it out because I do worry about long-term closure of the fistula. So I remove the lumen opposing stent and put a double pigtail plastic stent instead in all those patients.
Thank you. Keep on doing good work.
It was an excellent talk, Harshit. In spite of all the advantages of endoscopic drainage, the percutaneous drainage also cannot be written off. There are several advantages. It is very widely available and it is a time-tested procedure, safe. It can be done at the bedside, much cheaper. And of course, the availability of skill is so rampant, so it cannot be written off. So,
no, absolutely. And as per the Tokyo guidelines, the first choice is a percutaneous transhepatic drainage. And for all those points that you just mentioned, the availability of specialized equipment, the cost associated with these kind of procedures, as well as the skill set of the physicians, this is not something that could be done at every center, but I think wherever feasible, this would be a good alternative to think of.
So I have another observation about a nasocystic drainage. So if you have a very fit patient for surgery, young patient, where they will ultimately undergo a cholecystectomy and they are not fit for a laparoscopic procedure because of overall general condition. If you apply a nasocystic drainage, these drainage tubes can be pulled out, and also these stents, sometimes when they get blocked, you won't even realize that it is blocked. Nasocystic drainage tubes, you can check it, and subsequently they can undergo a lap cholecystectomy very sooner. If it is a prolonged time, it may not suit because patients won't carry this for a long time, and accidental dislodgement is quite common for these nasocystic drainage tubes. It is a very excellent, mind. I liked it overall.
Thank you.
Thank you.
So, Ravi
Dr.
sir,
Harshit,
yeah,
Dr. Harshit,
yeah.
I have
Yes.
a query for you. So we find difficult in achieving the stent position. Generally, when you start trying from the duodenum, we land up doing it in antrum. Is that going to be a problem? Because when the distended gallbladder is going to shrink away as the distension goes off, there will be a traction. So is there a problem, or you do expect such things like when you try in the duodenum and because of the technical difficulty you land up at doing in antrum? I just want your comments on this.
No, thank you so much. I think that's a great question. So I personally prefer transduodenal through the bulb approach because the bulb is relatively fixed. It's a retroperitoneal organ. And when you place the stent is pretty locked between the duodenum and in the subhepatic space. So I feel that even if the gallbladder shrinks, the stent, there is less risk of migration because the bulb, as you know, in the sweep is a relatively fixed position. Even with peristalsis, the bulb doesn't move much. So I prefer to do a transbulbar drainage. So even if the gallbladder shrinks, the stent has no place to move or migrate. Now, in some patients, it is just not feasible, in which case what I do is I puncture the gallbladder through the stomach, where I may see a transantral view, and I distance the gallbladder, and then I find a window through the bulb. So even though there may not be an initial window in the transbulbar area, a transgastric puncture brings the gallbladder towards the duodenum, especially if it's compressed or shrivel up, as Dr. Pal mentioned earlier. Now, in some patients, that is just not the case. You just can't find a window. I have done, and I'll say on an estimate, about 20-25% of my cases through a transgastric window, because that's just the window there is. But in those, even if I put a double pigtail stent, I think it's not been a problem. The main things is, of course, food impaction. Given that there is solid food in the stomach, the peristalsis with it increases the risk of the stent slippage. But I don't bail on it. If I do have a window, I do go for a transantral.
And also the fundus is more closer to the duodenum than antrum, and fundum is more wider from the duodenal angle.
Okay, Ravi sir, we have 5 minutes left. So can I just have your opinion on the fast talk? Like your opinion, like all 4 or 5 of us, about your opinion on US guided liver biopsy. In my opinion, I have started doing it. This is good. Like the complications, like usually with the percutaneous route, what we used to do was the pain in the intercostal area, because we don't know, we might be going through the nerve and all. And it was a blind procedure. So I think this is extremely helpful to us because we can see the vessels and accordingly do a liver biopsy. So in 1 minute each, I would like to have everyone's opinion about this US guided liver biopsy.
Yeah, I have done liver biopsies and sono guided, but they are not meant for a procedure. Initially, we planned for a liver biopsy. We have done for lesions, like if I do it for a pancreatic mass lesion, if I find the secondary, then I do it targeted biopsy from left lobe. But I have also done it for diffuse liver disease like cirrhosis, but those are all endosono planned for something else if on the way, and when we see diffuse liver disease, we do it. But generally, our center is a liver transplant center. Our transplant surgeon believes in percutaneous biopsies than endosono, and also the cost associated with it. One needle. So I have done few, but those are all initially not planned as a liver biopsy. But I did endosono for something else and ended up doing a liver biopsy for those cases.
Yeah, Dr. Bose, your opinion?
Yeah. I haven't had the experience of doing a US guided liver biopsy, but I think there are 2 situations where this would be quite exciting to perform. One is where while you are taking an FNAC from a pancreatic head mass or pancreatic body mass, and you are doing an US, you look at the liver, because now the liver can be scanned all the segments through an US, and then you find some metastatic, SOL lesions inside the liver, where you can target and do the biopsy in the same sitting. You don't have to ask the ultrasonologist or the person who is doing a liver biopsy on a separate session to do it.
No,
That's
here
one
we are talking
situation.
about hepatocellular indications, not about targeted, not about the mass
No,
lesions.
about hepatocellular indications, the situation, that is one situation I was talking about. The other is hepatocellular situations where you are supposed to rule out a cause of, say, extrahepatic obstruction when you are scanning for a cholestatic jaundice. So during that time, you don't find any obstruction. You find that the extrahepatic biliary radicals are absolutely normal. There is nothing inside. So then you have the opportunity of doing a ultrasound-guided, US-guided liver biopsy in the same sitting, and it's for a diffuse liver disease. So you don't have to subject to another session of trans biopsy. The complications and the things are the same. Here you can see the vessels, which obviously an ultrasound-guided liver biopsy, transpercutaneous ones will also be able to detect, but not a blind one. Of course, that is a better. But complication rate-wise and all those things are more or less similar. So why not? It should be done.
Dr. Arul, your comments? Yeah.
Yeah, in our situation, we haven't attempted any US guided liver biopsy, but we need more strong evidence, and probably it should be cost effective, because putting a patient for an US guided liver biopsy when there is a cheapest and safest technique is available, it's getting very difficult to convince the colleagues, surgical colleagues, or even our own patients to go for a US guided. And I have my own reservation of handling the bleeds post. We have percutaneous biopsy, and we can inject gel foam, and you can block the track if there is an high risk of bleed. But in US guided biopsy, it's going to be difficult to control the bleed. So it's very difficult to convince. So this is my view on US guided liver biopsy.
Yeah, Ravi sir. Sir.
I mean, there is one technique the speaker said about fanning. If it is a diffuse liver disease, we need not be worried about too much about fanning. You know, if you do fanning, sometimes you will create lot of traction on the capsule and some tear also. So if it is a diffuse liver disease, we need not concentrate too much on fanning, and even fanning in a very smaller area itself is good enough for this. Unlike you're doing for a tumor, then, you know, if you do a fanning, the chance of getting a positive histology is more likely. And moreover, the bleeding, I think we see smaller blood vessels, and most of the time we are able to avoid blood vessels in endosonogram, unlike in a percutaneous. You know, it's a high frequency ultrasound. So I thought the chance of bleeding is less, but if there is a risk of high risk for bleeding, like elevated prothrombin time, it is better to go for transjugular biopsy than even percutaneous is more risky in those cases.
And finally, Dr. Harshit, your opinion? We are just like our time is up. So finally, your final comments on this.
Thank you, Dr. Pal. Actually, Dr. Chahal's talk, as she mentioned, majority of the data comes from Geisinger, and that's where I'm from. So all the data was from actually our group. We've done a lot of publication and research on US-guided liver biopsy. In fact, at our center, we're also a big transplant center, and majority of our liver biopsies are actually done by US route. So I can quickly tell you what we do is patients who have abnormal liver enzymes who need workup done, instead of sending them to transabdominal Doppler or an MRI to clear a bile duct, and then if they have something they need a biopsy, that's a 3-stop shop. You know, they go to imaging for US, then MRI, then they go to IR for biopsy, or if there is a stone, they come to us for ERCP. So instead of that, what we do is we have kind of come up with this protocol I can share with you really quickly, is patients who have an elevated liver enzyme pathway, if they have elevated liver enzymes, we do an EUS, and if they have a biliary pathology, we can do an ERCP at the same time in the same session. If they don't have a biliary pathology and everything is normal, then we can get a US-guided liver biopsy at the same time. So I think in that regards, we've been able to have a one-stop shop where the patient comes in, and also many of these patients needs a Barrett screening or they have abdominal pain, so they can get their H. pylori biopsies, they can get EUS for a biliary rule out, and if they have a biliary issue, we convert it into an ERCP. No biliary issue, you get a liver biopsy. Patient wakes up and you have an answer one way or the other.
Harshit, I have a small question. I mean, we talk about so much about knowing exact anatomy, lobe, do we need such knowledge on anatomy for doing a liver biopsy for a diffuse liver disease or even a space occupying lesion?
No, Dr. Ravi. So for parenchymal liver biopsies, we personally do. So as you saw from the data that Deal et al. Was part of my group, we do bilobar biopsies. Again, we published that NASH can be patchy and you may have difference in staging of fatty liver disease. So we do bilobar biopsy, but we only do 2 actuations per lobe with only 1 puncture. And with that technique, we're able to, get adequate sampling.
Do we need to know whether it is segment 4, 5, 8, 7?
No,
such knowledge,
no.
does it require for doing a biopsy?
Not for the liver biopsies, no. So we do transgastric puncture, and wherever is the best and the deepest window, avoiding the vessels, we try to go for that area. You don't have to know, what segment you're hitting, and through the transduodenal bulb, you get the right liver lobe. So this way you can get right and left sides of the liver, but not necessarily what segment it's in.
Thank you.
Okay. Thank you very much, Dr. Harshit. I know it's like 1 a.m. in the morning in your place, but in spite of that, you have joined, and the discussion was really fruitful. Was very good. I would like to thank you from the organizing committee. Thanks for joining the session. And also I would like to thank for all my co-panelists and moderators for the excellent session. Thank you.
Thank you, guys.
Thank you.
Thank you.